Good morning. I will say that I am not sure I can see that we have Zoom set up, but I believe that it is. Would someone on Zoom be willing to say hello, just so that I know you're there?
Hello, I'm here.
Thanks so much. That's so great. So welcome to Geriatric Grand Rounds, Thursday, April 17th, just your morning orientation. We are really pleased to welcome back our annual pharmacy update. But before that, a few announcements. So our next Geriatric Grand Rounds will be May 1st. It will be our annual AGS, American Geriatric Society preview. And so this will be an opportunity for a subset of the individuals who are presenting at American Geriatric Society to bring those presentations here locally, because we know that not all of us, most of us, in fact, are not able to go to AGS. So we want to highlight the different presentations. So please come for that. We're really excited. We will have Journal Club coming up in May. And then please do fill out the evaluations. This is helpful for feedback. Also happy to hear any topics that you're interested for next year's Grand Rounds. We are starting to think about planning that. Submit questions into the chat and we will monitor that. So now I would love to introduce our speakers. It's really a privilege to have Dr. Sunny Linnebur here presenting first half. She's a professor at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. She's also a clinical pharmacist here at UC Health Seniors Clinic. Some of the aspects of service that Dr. Linnebur has been doing include serving as AGS president. We were thinking that that was 2018 to 2021, also serving on the AGS Beers Committee refresh that many of you reference daily or weekly, hopefully. Serving on the American Board of Internal Medicine, Geriatric Medicine curriculum committee, which writes the test questions from a pharmacy perspective. And then finally, recently reelected to the AGS nominating committee, which helps establish the board for AGS. So really, she is a wealth of knowledge for AGS and national leadership. Welcome to Dr. Charlotte Ricchetti, who recently joined Seniors Clinic as a pharmacist. She is also so let me give you a little bit about her background, since this is the first time she's had a chance to present here. We're so glad that she's part of the team. She earned both a bachelor's and doctorate in pharmacy from the Ohio State University, and then completed a pharmacy practice residency at the VA in Columbus, Ohio. She has provided clinical pharmacy services for over 20 years, helping to care for patients within the VA, 2 community health centers, and now at UC Health. She is a faculty member at Regis University School of Pharmacy for 8 years, and then recently joined the faculty here at Skaggs School of Pharmacy and Pharmaceutical Sciences. She moved to Colorado in 2010, loves hiking, snowshoeing, and spending time with family and friends. So we love Grand Rounds because it's a chance to highlight the team members who are part of our interprofessional team here. And I will turn it over for our new drug update.
All right, thank you, Dr. Lum. And can everyone hear me okay? This is the annual drug update. So we'll be mostly looking at a few of the medications that will be useful in the clinical care of older adults, or that may require special monitoring and consideration when used in our older adult population. And one, as we'll see, is just more that I think some patients will be asking about, but may not have enough information on our older adults yet. So today we'll be focusing on Jornavix for acute pain, Trivio for resistant hypertension, Pivya or Linva, and Blujepa, which we love the name of this one, all for the treatment of uncomplicated UTIs in female patients. Jornavix or sorry, I knew I was going to do this, so let's just get it out of the way. Suzetrigine is the first agent we'll be looking at. It is a potent selective inhibitor of the voltage-gated sodium channel 1.8. It was just FDA approved in January of 2025 for the treatment of moderate to severe acute pain in adults. It does have a standard 100 milligram load dose that is then followed by 50 milligrams every 12 hours for up to 14 days. There are some dose adjustments that are required for patients that have moderate to hepatic impairment or who are taking moderate CYP3A4 inhibitors. And we'll see later on where it's contraindicated in patients with drug interactions and liver disease. Kind of a quick review. The voltage-gated sodium channel 1.8 is a target for pain modulation due to the fact that it is highly involved in transmission of pain signals in the periphery, in the dorsal root ganglia, and the fact that it is only expressed in the peripheral nerves. It's not expressed in our CNS system. Suzetrigine does selectively inhibit the 1.8 sodium channel. So it doesn't inhibit some of the other sodium channels that are found in muscle tissues, cardiac tissues, which are responsible for side effects of some of the non-selective inhibitors. It does bind to a unique site on the sensory area of the channel that then stabilizes it in the closed position to prevent repolarization and transmission of that pain signal. In a lot of the preclinical trials, it was found that it does not bind to or inhibit any of the targets in the CNS, and then in clinical data, no signs of abuse or addiction potential. This slide summarizes the primary and secondary outcomes for the 2 randomized controlled trials that are available that look at suzetrigine versus placebo, but also had a control drug of the hydrocodone acetaminophen. I didn't include data for the open label trial that looked at acute pain, and I also didn't include data for the lower doses of suzetrigine just because they didn't show clinical efficacy. But what you can see here is the primary outcome, suzetrigine compared to placebo did significantly lower acute pain over that first 48-hour period. That primary outcome is SPID 48. Was not statistically different, though, for the hydrocodone versus placebo. I do want to mention that a clinically meaningful difference for this outcome really hasn't been well established. On the other hand, the secondary outcome of percent of patients that had more than 30% reduction in their pain score over that 48 hours, that has an established threshold. So if it's greater than 30%, or at least a 2-point reduction in the pain scale, that would be considered clinically meaningful. That's been established in chronic pain models and cancer pain. They didn't do statistical analysis on it because it was a small sample and because it was a secondary outcome. In terms of safety and side effects, the medications were well tolerated. Most of the adverse events were considered mild to moderate in nature. And you can see there was a very low discontinuation rate due to adverse or serious adverse events. The most common side effects seen with suzetrigine were nausea, vomiting, constipation, dizziness, and headache. And in both the trials for bunionectomy and abdominoplasty, they were either similar than or lower than placebo, with the exception of headache and constipation. Other side effects that have been seen in some of the trials with Geriatric include pruritus, rash, muscle spasms, and elevations in CPK that were greater than 3 times the upper limit of normal. Something to be noted, though, with that increase in CPK, these were all in a post-surgical setting. Patients did not have signs or symptoms of obvious muscle toxicity, and no patients required dose adjustment or discontinuation of therapy due to those elevations. Another adverse event that I kind of am keeping my eye on is this change in serum creatinine. So about 2.5% of patients in these trials experienced a change in their eGFR or a decrease in their eGFR of about 25 to 50%. In the open label trial, I did look at this one. They had a similar incidence of changes of eGFR. That trial followed patients for 14 or 30 days after discontinuation of the medication, and eGFR did return to baseline at their follow-up safety study or safety point. This is probably one of the limiting factors of the use of Geriatric for a lot of patients, is that it is a CYP3A4 substrate and CYP3A4 inducer. So it is contraindicated for patients who are currently prescribed strong CYP3A4 inhibitors. I've included a lot of common examples on this slide, but obviously the slide is not all inclusive. For strong inducers such as carbamazepine, phenytoin, modafinil, that can actually reduce the efficacy of Geriatric. So it's not a contraindication, but it is suggested to avoid use. And then our moderate CYP3/4 inhibitors would require that dose adjustment. After the third dose, it extends to every 24 hours rather than every 12 hours. And we can kind of see some of the cardiac drugs that we would probably see more commonly in our older adult patients. Similarly, Geriatric can impact the metabolism of some of our other medications, and use with sensitive substrates is not recommended either, or use with caution, because Geriatric can lower their efficacy. So I did again include some of the medications that might be more common, such as the ticagrelor, dronedarone, and Dayvigo that we may see in some of our older adult populations. I don't think we have to worry about hormonal contraception. Older adults, we'd love to see a non-opioid agent that's not Tylenol, because we know our patients don't love it. But unfortunately, only 6%, just over 6% of the patients in these studies were over the age of 65. So just not a whole lot of data in terms of clinical efficacy, or are there any higher risk of side effects? Based on the available pharmacokinetic data, age does not seem to impact the overall exposure and half-life and metabolism to suzetrigine, though. I did want to know if there are any long-term studies. None of this data is officially published in journals, but is available through the manufacturer. They did a 12-week study for adults aged 18 to 80 who were experiencing diabetic peripheral neuropathy. And they did show that all of the doses of suzetrigine, similar to pregabalin, had at least a 2-point reduction, that clinically meaningful reduction in pain scale over 12 weeks. Most of the side effects were similar: mild headache, constipation, but I did call out that the incidence of changes in creatinine clearance here were 5% in the suzetrigine group versus 1.9 in the pregabalin group. There was another study that was done over 12 weeks, a slightly younger population for painful lumbosacral radiculopathy. And the curve looks like there's a great reduction in pain scores, but as you can see, it is identical to the reduction of placebo. So because this is more centralized pain and not so much in the periphery, that's likely why there wasn't the effect seen. So to summarize, where does Geriatric fit? It is FDA approved for acute pain of less than 14 days. I would argue there's very limited data in your older adult populations. However, you may consider it for some of your patients that just don't tolerate opioids, who aren't finding benefit from over-the-counters or topicals, with a close eye on those drug-drug interactions. Because of the types of surgeries that they studied to mimic soft tissue and bone pain, over 76 to 100% of the patients in these two trials were women. It does have a delayed onset of action. So in the bone pain study, it was up to 4 hours, and in the abdominoplasty, it was about 2 hours. And so that is why it requires that load dose. And for some patients in the early phases of that acute pain, they may find that they're still taking Tylenol. One of the benefits is that it does have a long duration of action. So for patients who can't take multiple doses or need a more prolonged action, that might be a benefit. It does cost about $500 for 15 tablets or for 30 tablets. There are some copay assistance cards, and patients with Medicare may even qualify for them. Trivio, or aprocitentan, is a dual endothelin receptor antagonist that is the first of its class to be approved for treatment of resistant hypertension in combination with other medications. Due to its long half-life, it does allow for once daily dosing, has very minimal risk for drug-drug interactions, which makes it great. One of the barriers to prescribing it is that you can only send it to the Walgreens specialty pharmacy, and it has to come from there. When it first came out, there was a REMS program that providers had to register for, but luckily that has since gone away. lovely busy slide, but I just love to know how medications work exactly. So in endothelial tissue, activation of the A and B receptors on smooth muscles of the blood vessels actually leads to vasoconstriction. Conversely, activation of the endothelin B receptors on the endothelial tissue of those blood vessels can result in vasodilation. However, in hypertension, the vasodilatory properties of the B-type receptors is dysfunctional, and there's an upregulation of the B-type receptors that cause the vasoconstriction. In the kidneys, in a healthy kidney, we see the B-type receptors leading to vasodilation and natriuresis that is mediated by nitric oxide. But in the disease state, so hypertension and hypertensive kidney disease, there's a shift. Those B receptors are dysfunctional. And so there's actually an upregulation of the A receptors that lead to vasoconstriction and sodium and water retention through activation of the RAS system. So Trivio can inhibit the vasoconstriction, activation of the RAS system, and may have some anti-inflammatory and anti-fibrosis properties as well. The clinical data that is available for Trivio was done in the large precision study. It was a multi-center blinded trial. It was conducted with multiple phases. Patients had to be on 3 medications prior to enrollment and still have uncontrolled blood pressure, and they validated that in various ways. And then before being enrolled in the trial, patients were switched to a standardized regimen of max dose ARB, max dose hydrochlorothiazide, and 2 different doses of amlodipine. If patients were already on a beta blocker, they could continue that through the study. 60% were men, 80%, over 80% white. But this study did include a significant proportion of patients that were over the age of 65, 44% if you include the 10% that were over 75. Very nice reductions in blood pressure. So Trivio at both doses, 12.5 or 25, lowered systolic blood pressure by 15 millimeters of mercury and diastolic by 10. Why I included that graph is just to demonstrate that the placebo had a really nice blood pressure reduction as well, 11 millimeters of mercury on the systolic. So about a 4 millimeter difference from placebo. However, this medication was more effective in the older adult patients, those with an elevated baseline urine to albumin creatinine ratio, and those with stage 3 and 4 CKD. Another positive outcome that was seen was a reduction in albumin to creatinine ratio of about 28 to 31%, as opposed to about a 5% increase in this ratio in patients who were on placebo. And the impact and benefit on urine to albumin creatinine ratio was higher in patients with stage 3 and 4 CKD also. In terms of side effects, the main side effect to worry about due to the vasodilation is peripheral edema. And this is likely why the 12.5 milligram dose is the one that's FDA approved. It had the same blood pressure lowering, but about half the incidence of peripheral edema. To put it into context, amlodipine 10 milligrams has about an 11% incidence of peripheral edema, whereas the 5 milligram only has about a 3 to 5% incidence of that peripheral edema. Due to the fluid retention and edema, they did look at anemia and hemodilution, which was about 3.5%. And because bosentan, one of the previous medications in this class to use for peripheral arterial hypertension, does cause hepatotoxicity, they did look for that in this trial as well and saw a very low incidence. In terms of warnings and precautions, we don't want to use it in our pregnant older adults. It is contraindicated in severe hepatotoxicity and or severe hepatic impairment and individuals with AST or ALT transaminases greater than 3 times the upper limit of normal. It should be discontinued if a patient experiences a clinically relevant, which they don't define, but a significant increase in AST or ALT, especially if accompanied by an increase in the bilirubin. Fluid retention and edema, the risk factors for that were found to be older age and CKD. And because of the risk of that fluid retention, patients who had class 3 or 4 heart failure, unstable cardiac conditions, or elevated BNP were not included in the trials. It may impact spermatogenesis, so if that's important for patients, that would be an educational point as well. In terms of where it fits in place of therapy, this is probably a really busy slide, but it is a summary of the 2018 American Heart Association guidance document on treatment of resistant hypertension. So after ruling out secondary causes, ensuring adherence, optimizing diuretic therapy, our next step is to consider a mineralocorticoid receptor agonist, such as the spironolactone or a eplerenone, doing a double check on what's their renal function. Is the clearance above 30? Do they have high potassium? And then from there, the next steps are more based on expert opinion, but moving into, are they a candidate for a beta blocker? Should we add hydralazine or substitute and switch to minoxidil? So I tried to think about a patient where I would maybe consider Trivio. And so this is loosely based on one of our patients that we do see in seniors clinic, very loosely based, 78-year-old female with hypertension, AFib, CKD. She borders on stage 3, 4, but she does have high levels of protein in her urine on carvedilol, max dose amlodipine, irbesartan, furosemide. Blood pressure not a goal, but her heart rate is at the lower end of the 60s on her carvedilol. Her EGFR, it is stable. It's monitored regularly, but hovers right around that 30 milliliter per minute mark. And potassium is stable too, but also towards the upper limit of normal. So I'm just curious, I've given you a lot of time to think about this. How many people would most likely start the spironolactone? Doxazosin? Hydralazine, everyone's favorite med. Maybe. Trivio. Maybe. Like I do struggle with some of patients where I'm like, I don't love any of my choices. The guidelines and the Pathway 2 trial would suggest spironolactone as your next choice. However, the patients in that trial, their average creatinine clearance was 90 and their average potassium was 4.0. So yes, low incidence of high potassium, but certainly not this patient. Doxazosin was one of the comparator drugs in that trial, and it did have an 11-point reduction or 11 millimeter mercury reduction in blood pressure, but we know that orthostasis and other side effects may limit it. She's already on carvedilol, yeah. And hydralazine, I just don't like the frequency for which our patients have to take it. So would I be tempted to consider Trivio? Maybe, but high cost, and I mean, she'd be at risk for edema. So I just think it's going to be individualized, and there's no great answer for this one. I'm just going to very quickly go over 2 new drug approvals. They weren't on our previous slide, but they have new drug approvals for COPD and are included in the GOLD guidelines for 2025. The first is Ohtuvayre, which if you say it with a Northeastern Ohio accent, Sunny, it's Ohtuvayre. And it was approved in June of 2024 for the maintenance of COPD. It is a nebulizer solution, and it inhibits phosphodiesterase 3 and 4, so has some bronchodilatory properties as well as anti-inflammatory. About 55% of the patients that were in the 2 major trials were over the age of 65, and the primary outcomes that showed a positive result were improvements in lung function, as well as dyspnea that resulted in reduced use of as-needed therapy. There was a trend towards reduction in COPD exacerbations, but it didn't fully achieve statistical significance. And the authors of the GOLD guidelines kind of felt that the trial wasn't fully designed to evaluate impact on exacerbations. So their current recommendation is it could be considered as an add-on therapy to patients who are still symptomatic that's affecting their quality of life if they're already on optimized LAMA and LABA therapy. Dupixent is already FDA approved for a number of indications, including eczema and asthma. So this is just a new indication under its belt. And in its primary trials, it did show a reduction in exacerbations. So the current GOLD guidelines recommend that for patients who are already on optimized LAMA, LABA, and in ICS, who are still experiencing exacerbations and who have eosinophilic type COPD, that you can consider this as add-on therapy. And with that, I'm going to turn it over to Sunny.
Thank you, Charlotte. So one of the things I think is so awesome about doing this Grand Rounds is I get to practice pronouncing new drug names. And also, one of the best parts of working in academia is learning myself. I get really excited about learning about these drugs. And as Charlotte mentioned during the hypertension part, sometimes our options in geriatrics are what's the least bad drug for our patients, right? But today I'm going to talk about 3 new antimicrobial agents that were all recently FDA approved in the last year for uncomplicated UTIs. And just as a refresher, what does uncomplicated UTI mean? Well, it means that the patient has an infection of the bladder, so not pyelonephritis. It also means that, and we're talking about women, these were all 3 approved for women. Men are complicated UTIs. It also means that they don't have a catheter present. It also means that they're not pregnant and that they're not immunocompromised and that they don't have any structural abnormalities of the urinary tract. But even with all of those exclusions, there are many, many millions of women that have urinary tract infections in the United States each year. And even like Jacob and I were talking about, patients with HIV, if they're well controlled, would be still in the uncomplicated category. So today I'm going to talk about Pivia or pivmecillinum. I'm going to talk about Orlinva, which is sulopenem and probenecid, and then Blujepa, gepotidacin, also I agree, best name of the year. So let's start with Pivia or pivmecillinum. These first 2 drugs I'm going to talk about are beta-lactams. The third drug is a new mechanism of action. So Pivia was FDA approved almost a year ago, April 24th, for uncomplicated UTIs, women over 18, for specific bacteria. All 3 of these antimicrobials have their own specific bacteria. So I'll have a slide near the end that goes through what those bacteria are. But E. coli, Proteus, and Staphylococcus saprophyticus. When we think about UTIs, they're usually caused by gram-negative bacteria, but there are a couple, Enterococcus and the Staphylococcus, that can cause UTIs as well. So we have to be able to cover empirically if we don't have culture and sensitivities for both gram-negative and gram-positive. And beta-lactams can treat both gram-positive and gram-negative. This is a penicillin, so it's a new penicillin, supposedly in Europe for decades. But no one I know knows a lot about it, but it's supposedly been approved there for decades. It just got approved in Canada around the same time as in the United States. And the FDA approval is different than the approval in Europe. So there are a couple things to keep in mind. One is the dose. So in the United States, we have 185 milligram 3 times a day for 3 to 7 days. In Europe, they have 400 milligrams, which is a different salt form, about the same as 200 milligrams of what we have. This drug is a prodrug, so the active agent is mecillinum, and so it has to be converted by esterases to that active moiety. It interferes, like all beta-lactams do, with the bacterial cell wall, and it inhibits penicillin-binding proteins. But because it is active against the penicillin-binding protein PBP2, it may have some activity against extended beta-lactam ACE-producing bacteria. So in clinical trials, Pivia was compared in that same dose, 185 TID, for 3 days and 7 days. And it was compared against placebo and ibuprofen and found to be superior to placebo and ibuprofen. That's good. It was also compared in the active comparator trial to cephalexin. Cephalexin dose was pretty low, 250 QID for 7 days. Now, on all 3 of the studies, they have the same type of outcome. So when they look at the outcome, it's a composite outcome of a clinical cure, meaning that their symptoms are gone, and also a microbiologic cure, meaning that the bacteria have been reduced to less than 1,000. And that is at slightly different time points in the studies, but that composite outcome is what is the stats are based on. And what I did learn, which I didn't know before this, was that beta-lactams are not always the best at totally clearing the bacteria. So meaning that we will have patients who don't have symptoms, they're gone, so they're clinically better, but they'll still have asymptomatic bacteria. And so I didn't realize ciprofloxacin, which is the comparator of the next drug, crushed the microbiologic cure compared to beta-lactams, not quite as good. So what I did like take away from that was if your patients don't have symptoms, don't check. Don't check their urine because you might find bacteria still and then you're like, what do I do with it? And really it's just asymptomatic bacteria, which we all know we don't treat. So back to Pivia, placebo, ibuprofen, it was superior, but it was similar to cephalexin for the composite response rate. So 72% versus 76%. But they didn't break it down based on if it was sensitive or resistant to cephalexin. So the next two drugs we have that breakdown. In terms of data in older adults and renal impairment, there's a lot of stuff on this slide, but they found no overall differences between the efficacy and safety with older adults. However, only 13 to 14% were over 65 and a tinier amount, 3% were over 75 in these studies. And they were pretty small studies. It does get renally eliminated with most beta-lactams do. And so when we think about that, it could build up, but there's no evidence to say that it needs to be renally dosed or avoided in any patient population. Side effect wise, it was super well tolerated. Nausea was the most common side effect, up to 4.3%. You can see, like with most antibiotics, they can cause diarrhea. Vulvovaginal candidiasis occurred a little bit. And then very rarely in the post-marketing surveillance, there were some skin reactions. Contraindications wise, because it's a penicillin, if a patient has a very severe hypersensitivity reaction, so anaphylaxis to a penicillin previously, you wouldn't want to use it. But if it wasn't severe, it is a potential option. It also has some other weird contraindications, meaning like super rare. So if a patient was primary or secondary carnitine deficiency from an inherited disorder, that's so rare, but patients usually are aware that they have to be careful with other drugs. Acute porphyria too. And when we think about the warnings, precautions, like all of them have C. diff warnings because antibiotics can cause C. diff. And then this one has the severe skin reaction warning. So if a patient has specifically had like Stevens-Johnson history, probably wouldn't want to use this drug. There are a couple drug-drug interactions. Valproic acid, due to the carnitine depletion risk, valproic acid binds to carnitine and then will remove it from your body. And so then you can get a carnitine deficiency, and we need that to break down fat into energy. So that can be an issue if someone is on valproic acid regularly. And then this is just a good reminder for all of us, methotrexate interacts with all penicillins and most cephalosporins. So what happens with methotrexate is you should avoid penicillins and cephalosporins if you can, because they inhibit the renal excretion of methotrexate, and then methotrexate levels go up. And it's hard to quantify that, so it's better to just skip that drug class, but sometimes we forget about that interaction, and it applies here as well. All right, we'll take questions at the end, but next moving on to Orlinva, which is sulopenem probenecid. So you probably recognize the penem part. This drug is a carbapenem, and we have inpatient IV carbapenems available, but this is the first oral carbapenem. It was FDA approved October 24th for uncomplicated UTIs, again, 18 and up females, but different bacteria. So E. coli, Klebsiella, and Proteus. One thing that is really interesting about the label of this drug is the FDA, it was studied for outpatient after inpatient use, and it was specifically studied for like a step-down therapy. So they're on a carbapenem IV for UTI, they go to this oral agent, or also intra-abdominal infections, step down from like an IV therapy, and it was not more effective than the comparator. And so, for example, in the UTI study, they looked at sulopenem IV, step down to this drug, versus ertapenem, step down to Cipro. Not better than that treatment. And so for the first time I've seen this, the FDA like put in the label, it is not indicated for the primary or step down treatment of complicated UTI. So like, do not do it. I wish they did that for other drugs like memantine, where it doesn't work for mild dementia, yet doesn't say that in the label. So interestingly, I think it'll still be used for that, the step down, but it says it doesn't work. This is another prodrug, so it's hydrolyzed to the active penem antibacterial drug sulopenem. The probenecid is there specifically, I mean, probenecid's for gout, right? So the probenecid is there to prevent the tubular secretion of sulopenem, thereby increasing the blood concentrations of the sulopenem. And if Jacob was here, I'd call him out because he knows that probenecid is also used to like boost penicillin for syphilis and stuff like that. So probenecid is, although for gout, a drug that we use to increase blood levels of other drugs. Sulopenem, like the carbapenems, binds to peptidoglycan and inhibits the cell wall synthesis. Again, it's a beta-lactam, and it may be effective against the ESBL producing gram-negative bacteria. Its dose is 500 BID for 5 days. So the probenecid dose is exactly the same as the gout dose. Probenecid was, Orlinva was studied against ciprofloxacin and augmentin. The ciprofloxacin dose was 250 BID for 3 days. These are way bigger studies than the Pivia studies. And then it was studied versus augmentin 875 BID for 5 days. So decent antimicrobial doses there. And what they found was that Orlinva was more effective than ciprofloxacin for that composite response rate. But when they broke it down by sensitive and resistance to ciprofloxacin, the results were a little bit different. So MMITTS means the microbiologic modified intent to treat group. And they looked, the S is sensitive to ciprofloxacin. And it was not non-inferior to Cipro in that group. And that was because Cipro crushed the microbiologic cure, meaning that the Orlinva had higher asymptomatic bacteria. But the clinical piece was similar. But in the resistant to ciprofloxacin group, where you'd expect it to not work as well, Orlinva was superior to ciprofloxacin. When they looked at the augmentin, again, it should theoretically be more effective than augmentin if there's resistance with beta-lactamases, perhaps. It was superior to augmentin. So 61% versus 55% in the sensitive group. And then the resistant group, it was too small to have statistical difference. In terms of data with older adults, there were more patients that were older in these studies. So whereas the other one was like 13 to 14%, this is 20%, 26% of people over 65 and 7 and 10% over 75. No overall differences based on age again. No overall clinically meaningful differences in PK. However, sulopenem is renally eliminated, right? And that's how most penicillins are eliminated. And because of that, they have a statement that it's not recommended in patients with a creatinine clearance less than 15 or on hemodialysis because of the risk of increased levels. Now, again, what would that mean? Who knows? Side effect wise, it's pretty well tolerated. Diarrhea is the most common side effect, 10%. You can see again, it causes vulvovaginal mycotic infections. Most antibiotics that are broad spectrum do, and rare hypersensitivity reactions. So pretty well tolerated. Contraindication-wise, again, it has that same warning, serious hypersensitivity to beta-lactam drugs. It can cause some blood dyscrasia issues. If someone already has that, then you wouldn't, it's rare, but you wouldn't want to use it. Because of the probenecid piece, it can, in someone who's not controlled for gout, cause an acute gout attack. So if someone has a gout history, you got to make sure they're already on something else like allopurinol. It's a short treatment with probenecid, but you don't want to cause gout attacks. And also it can cause kidney stones from the uric acid excretion, because what probenecid does is it will prevent uric acid reabsorption in the kidneys. It does have an interaction with NSAIDs. It can increase the levels, and specifically ketorolac. So it's probably randomly used, but you never know in the ER. Wouldn't want to use it. And then methotrexate, same interaction. And then we think about sulfonamide allergy because there's some cross reactivity with it as well, which is because of the probenecid. Okay, the coolest one, Blue Jeppa. That's why these slides are blue. Blue Jeppa was just approved a couple weeks ago, March 25th. I've been waiting on it, and so I have a little bit more data on it from the older adult population. It was FDA approved for 12 and up, so it has a broader approval, but you have to weigh at least 40 kilograms, and it has more bacteria that it's covering. So E. coli, Klebsiella, Citrobacter, Staph, and Enterococcus. This is a brand new drug class. So this is, like, if I can say this correctly, triazoxanoaphthylline, antibiotic. PharmD gets me the pronunciation. So this drug works kind of like doxorubicin, which is an oncology drug, but it inhibits bacterial DNA replication by inhibiting topoisomerases, so 2 and 4. And so it's brand new mechanism of action, which is awesome because we don't have to worry about the extended spectrum beta lactamases. We don't have to worry about penicillin allergies. So there's some pros. It's dosed 750 milligram tablets. I haven't seen them. I haven't seen a picture, but I'm guessing they're large, and that's why it's not a 1500 milligram tablet. But it's 752 tabs, Q12, for 5 days. Another really random thing about this drug is that it's a cholinesterase inhibitor. So like our drugs for dementia. So because of that, it has GI side effects, and that's why you have to take it with food to prevent the GI side effects. So looking at the EAGLE-2 and EAGLE-3 study, this is Blujepa versus nitrofurantoin. So nitrofurantoin is one of our main drugs for UTIs, and so they compared in both studies nitrofurantoin 100 BID for 5 days, so pretty good comparator. And they found composite response in both trials was more effective than nitrofurantoin. So 51.8% versus 47% with nitrofurantoin, that composite response, 58.9 versus 44 in the second trial. It was considered then non-inferior, but did have higher composite clinical cure rates. This is the data that I was able to get from the manufacturer before it was published, but the data based on age, they did look at the over 65, over 75 group, and it was way more effective, like double the effect rate in the older adult population compared to nitrofurantoin. So that's awesome because oftentimes we may need to not use nitrofurantoin. And then they compared the outcomes based on bacteria. So in all but the Staphylococcus, it was more effective than nitrofurantoin. So more effective in the E. coli, Klebsiella, Citrobacter, and Enterococcus. Data in older adults, again, they had about 15% that were over 65, 8%, but they said no overall differences in safety or effectiveness, and that's because they don't have the power to show a better efficacy, but as I showed on that previous slide, there was better efficacy in the older adult group. It is renally eliminated. And so because of that, we do have to be careful. And they didn't prospectively include people in the 30 to 60 eGFR range, but they had a bunch of patients in that range. So they're able to kind of see what happened, and it does build up. But the approval is no dose adjustment unless they're less than 30, and then you can't use it. So we would not use it in patients with a creatinine clearance or eGFR less than 30 or those with dialysis because of risk of QTc prolongation. So side effect wise, because it's a cholinesterase inhibitor, GI side effects are the main side effect: diarrhea, nausea, abdominal pain, flatulence. The other side effects pretty rare, but the ones we have to, most concerning would be that QTc prolongation. So you can see a prolongation of 30 to 60 milliseconds, but that's only in 2% of the patients. Again, they didn't include a super sick people. So if you have someone whose QTc is close to 500, I probably wouldn't use this drug. And then we know cholinesterase inhibitors cause bradycardia, so I asked specifically for data on that. And the cardiovascular adverse events, including bradycardia, occurred in less than 1% of people. It's a short treatment, so it's a little bit less of a worry. Contraindications-wise, just severe hypersensitivity, so wouldn't know that unless you tried it. If they have QTc prolongation, there's a warning. If they have hepatic inhibition or hepatic impairment, there's a warning. If they have that eGFR less than 30, we probably wouldn't use it. And then, of course, C. diff. The main thing is the drug interactions with cytochrome P450. So it does go through CYP3A4. It's a mild inhibitor of that. But if someone's on a CYP3A4 strong inhibitor, like they're on ketoconazole or something, then you would want to avoid it. And if they're on an inducer, then it may not work as well. So those are the issues. And then digoxin has a drug interaction with that, just saying like we should monitor their dig level. So what do the guidelines say about treating uncomplicated cystitis? The Infectious Disease Society of America, IDSA, those are being redone right now. I do not think they will add any of these drugs. The reason they won't add these drugs is because they are FDA approved for specific bacteria, and you wouldn't know what bacteria they have if you're treating empirically. Right? So these guidelines are for empiric treatment where we can't get a culture, or we're not going to because they're a younger woman. So in geriatrics, we most often have a culture and sensitivity, thank goodness. So then we can tailor the treatment. So if you can't get a culture and sensitivity, the 2022 AUA, or American Urologic Society guidelines recommend nitrofurantoin, Bactrim, and fosfomycin as first-line therapy. In Europe, they have a slightly different recommendation because supposedly they've had pivmecillinum for decades. So their recommendations are fosfomycin, nitrofurantoin, and pivmecillinum. And then alternatives could be a cephalosporin. Alternative, if your E. coli resistance pattern is good and you don't have greater than 20% E. coli resistance to Bactrim, you could consider Bactrim. But let's look at the state of Colorado antibiogram, and guess what? We have a 76% sensitivity rate to E. coli with Bactrim in Colorado. So we would not think about using Bactrim maybe first line for our patients empirically because of that, if it's E. coli, which is the most common bacteria of UTIs. The other things that I think are interesting here, Enterococcus is gram-positive. We don't have any data on amoxicillin. We don't have any data on Bactrim for that. In the gram-negative antibiogram, when we look at E. coli, it's pretty sensitive to FM, which is nitrofurantoin. So 97% in Colorado is sensitive to nitrofurantoin. But you can see Enterobacter and Klebsiella not as good. About 70% are not susceptible to nitrofurantoin. So that is where we may see resistance patterns, and we need to choose a different antimicrobial. So these are, again, they're specifically indicated for certain bacteria. So these are the bacterial coverage comparisons of these new agents. They all cover E. coli because otherwise they're not getting approved for UTIs. But then you can see Klebsiella is covered by Orlinva and Blujepa. Staphylococcus we don't have approval for Orlinva for that. And then Proteus, which is the least common, pretty rare UTIs, Pivia and Orlinva are going to be covering that. And I'm happy to send these slides out to anyone because I made these tables because I personally was like, I need these tables for when you come to my office and ask me a question. So I'm happy to send these out to anyone. So where do these agents fit in? Well, current guidelines recommend nitrofurantoin, fosfomycin, and Bactrim, and then if that E. coli resistance is less than 20%, and then pivmecillinum in Europe. So when we think about options, patients have to have good kidney function for nitrofurantoin. So if they don't, then we may be looking for something else. Also, nitrofurantoin and fosfomycin, they're usually on formulary, but sometimes they require a PA, and sometimes that PA is because nitrofurantoin's on the Beers list because of the kidney function issue. And then an E. coli resistance in Colorado is greater than 20%. So empirically, Bactrim's probably not on my list. For all these three new drugs, we really need a culture and sensitivity report, and where some considerations of where a drug may need to be avoided. So in summary, if they have a severe beta-lactam allergy, Pivia and Orlinva need to be off the list. If their QTC is close to 500, or they're taking CYP3A4 drugs that inhibit it, or they're already on a cholinesterase inhibitor, like they're on Exelon patch or they're on donepezil, I'd probably not use Blujepa, unless they're okay with the GI side effects. If they have severe kidney impairment, Orlinva, Blujepa, not on my list. If they have a history of gout or kidney stones and they're not controlled, I would avoid Orlinva because of that probenecid. If they're taking methotrexate, we need to avoid the penicillin drugs, so Pivia and Orlinva are out. And then if they're taking valproic acid, Pivia is out. This basically just means like job security for pharmacists here. So many things to remember. So I took some patient examples from our clinic, their culture and sensitivity reports, and I popped them in here to like talk about some examples. So this patient has an E. coli infection. They have side effects with nitrofurantoin and they have good kidney function. So based on the susceptibility report, if you look here, it's resistant to almost everything. It's resistant to Bactrim, amoxiclav, all the oral cephalosporins, Cipro, and Levo. So, and if they have a side effect to nitrofurantoin, we have IV drugs left. So this is a great example of like, what are we going to do? We got IV drugs. Are we going to admit them? Maybe we have been previously, but now we have some options. So in this patient, we could consider fosfomycin. So one of the things that like really drives me crazy is that fosfomycin is not on our sensitivity panel. And so I reached out to our ID pharmacist and she said that they had requested it. So they're requesting it specifically for when the patient's urine E. coli or Klebsiella is not sensitive to ceftriaxone, and that means it's probably producing extended spectrum beta-lactamases. And so then they're considering that at the lab. It's just not in the standard panel. But because fosfomycin is not on the panel, we don't know if it's sensitive to fosfomycin, but the resistance it's about 20% resistance rate. So it could be sensitive, but we don't know. But you could try it, and if they fail it, then you'd have to switch therapies. But now we have Blujepa. Blujepa is a new mechanism of action. And so even though this is E. coli ESBL producing, most likely, it won't matter for Blujepa because it has a different mechanism of action. And because they have good kidney function, they could take it. So then we'd be screening for things like QTC, drug-drug interactions, that kind of stuff. Also, Orlinva may be effective because this panel shows that it's effective are susceptible to ertapenem and meropenem, and they're both carbapenem. So theoretically, it may be effective. I put question mark Pivia here. I probably wouldn't choose that, but theoretically, it could have a little ESBL producing bacteria efficacy. This is a Klebsiella pneumonia. This is one of our patients who had 2 strains of Klebsiella in her urine. And the susceptibility report rules out nitrofurantoin. So Klebsiella, if you remember that antibacteriogram, only about 30% of the time in Colorado is Klebsiella susceptible to nitrofurantoin. So this is a perfect example of that. Penicillin allergy that she has a rash. So does it rule out amoxiclav, Pivia, cephalosporin, or Orlinva? It rules out Augmentin. We're not going to do it, but you could use those others because it's just a rash if you confirm. Now, when I confirm, people are like, I don't know what happened. And so I'm like, did you have shortness of breath? I don't know. So then guess what? Those are off the table. So not worth it, right? So then again, fosfomycin may be okay. We don't know. Bactrim, though, it's susceptible to Bactrim on this, and Blujepa, it would be still very effective against Klebsiella. Klebsiella is one of the bacteria that Blujepa is approved for. And then this one's Proteus, the least likely anaerobic bacteria that we see causing UTIs, but still we see it. So this patient has no drug allergies, poor kidney function though, eGFR 28. So when we look at the susceptibility report of this Proteus, it rules out nitrofurantoin and it rules out Bactrim. Poor kidney function rules out nitrofurantoin as well, because we can't use it if their eGFR is less than 30, it won't work. But again, it was already resistant. And then Blujepa, also, it's not approved for Proteus too. And then probably the fluoroquinolones, because we don't want to deal, I mean, we could renally adjust fluoroquinolones, but there are a lot more side effects. So those are probably off the table. So then it would leave us with the cephalosporins, Augmentin, fosfomycin, Pivia, or Orlinva. So we just have a lot more options now, which is awesome. When I say option, I mean option because who knows if these will be, I know they'll be prior auth, but who knows how hard it will be to get them covered. So what I would recommend is if you have a patient that you think you want to use one of these agents, that you send the prescription immediately to the pharmacy so that we can see A, can they get the drug, and B, what is a prior auth going to occur. If they're past their deductible season in January, February, the drugs probably has a decent coverage. If they're in the January, February deductible season, they're probably paying full price. I don't know any prices. There are no prices for any of these drugs yet. So that's it on the antimicrobial coverage, but there were some other cool drugs. This was like the first year in a long time where we had so many drugs that we wanted to talk about that we couldn't fit them all in. But there are some other drugs like FYI, benzgalantamine for dementia. Why you'd come out with a prodrug of galantamine, I don't know, but it got approved. And then there's a new drug for steatohepatitis. There's a new drug for schizophrenia, which is xanomeline and trospium. Trospium's the treatment of the cholinergic side effects of the other agent. It's like a prescribing cascade in one pill. And then epitome, which is for weight management, which is a hydrogel ingestible device. Kind of interesting. And then there's a nasal spray coming. It got denied, right? For AFib. So if you couldn't hear that, Charlotte was saying that the nasal spray for paroxysmal AFib was clinically effective. It had contaminants, so it's like pending right now. Thank you guys so much for your attention. What kind of questions do you have?
Wonderful. Great. Thank you so much.
Thank you. That was really interesting. I had a question about the first part of the talk, the endothelin-1 drug. You mentioned that it could have an effect on the renin-angiotensin system. Can that drug bind to 18-1 receptors and block Ang2 and then prevent vasoconstriction, or can it also have an effect on the expression of those receptors? Can it shift to the MOS receptors as well, or is it just specific to endothelin-1? How does that work?
It specifically binds to endothelin-1 receptors, but endothelin-1 activation can lead to increased aldosterone release. So it's reducing aldosterone release that
Okay.
way.
Interesting. Okay, second question for the second half. The antimicrobial drugs, a lot of the side effects were diarrhea and a little bit of nausea. These new drugs at the dose and the administration, is there any evidence that it could cause leaky gut?
That's a great question. So the question was about leaky gut. I don't have an answer for you on that. GI side effects are pretty much in every drug causes GI side effects because patients will get GI side effects in the study and they have to report it from the drug. But penicillins and cephalosporins traditionally do cause a little bit of nausea, vomiting, diarrhea. And so that is expected, but I don't know about leaky gut. I'm not sure.
Thank you.
Sorry.
Carrie Moreau.
Thanks for that update. I'll be using many of those drugs soon. I have a question for the first one. I don't know how to say it. Jornavax, that one?
Jornavix.
Yeah, okay. So we know that there's evidence that older women, the pain meds are less effective in them and have to be on it longer. In those initial trials, I know it was predominantly women, it looks like. What were the age range and did they look to see if, older women had even more even side effects or just less effectiveness of the medications or need to be on them longer?
So the age range was up to 80, I believe, in the one trial. Only 6% of the patients were over the age of 65. And then I'm sorry, the second part of your question.
Yeah, just side effects in general. So, the fact, I think they probably need to do more trials with an older cohort, given that after menopause, the effectiveness of pain meds wanes in women. So,
Right, yeah, no, I feel like they don't have enough clinical data in the older population to say it clinically, is there a difference for efficacy or side effects? All we have is the available pharmacokinetic data that suggests there's not a difference in exposure.
thank
Yeah.
you.
And I mean, all new pain meds, for the most part, test their drug in bunionectomy models because it's a reproducible, like expected acute pain. And that's usually younger women that are getting bunionectomy. I mean, so it's kind of just also the way it goes with new pain medications and how they're initially studied.
This is slightly off tangent, but I heard you say that fluoroquinolones are better. and that maybe we should be thinking about using them more often in people who have recurrent infections. I don't know if that's true, but that's what my brain heard. So is that true?
That was really reasonable summary of what I said. So what I learned from this was a lot of our, I looked at a whole lot of culture and sensitivities in our patients to try to pick out good ones for these slides. And I did find that many patients their bacteria are sensitive to fluoroquinolones. And I think sometimes we don't use them. They're not in the guidelines for empiric therapy because they have a lot of side effects and QTC and that kind of stuff. But they are very good at microbiologic cure. And so I think if it's on the panel and it is something that it's susceptible to, I think it's a reasonable agent. If you go, like in someone who does have recurrent infections, these guidelines right here, the 2022 ones are actually recurrent UTI guidelines. Those, don't have fluoroquinolones in there empirically. Let me find it. This guy, they recommend nitrofurantoin, Bactrim, and fosfomycin. But if you know that it's sensitive to it, I think it's a good choice. As long as we renally adjust, we do have to think about renally adjusting. And like, for example, one of Maria's patients who I recommended Cipro on, and it worked for the UTI, but dang it, she had an Achilles tendon rupture from that levofloxacin. So that, random side effects that occur in our older adults at a higher rate. So, pros, cons, but kind of, yeah, I mentioned that.
Thank you for a great talk. It's quite more based off just generality of the application of these drugs. They're FDA approved. The first thought is there consideration of sex and ethnic based differences when you get FDA approval and then how you think about administering those? And then secondly, I noticed that all of them are dosed on a blanket milligram dose generally. Is body weight ever considered when dosing these drugs?
Well, I'll just go on the antimicrobial side. So for example, when we look at the weight of 40 kilograms, so with Blujepa, it is based on weight, meaning like they need to be at least 40 kilograms in order to use it. There was a weight-based one for minimum also for Paxlovid. And so sometimes there are minimum weight based on the pharmacokinetics of the drug, but traditionally there's not a lot of requirement to study the drugs in women versus men. There's barely a requirement to have any PK data in older adults. So the requirements for approval are very low, and only if the drug's been studied for a long time somewhere else for another reason do we often have those data at FDA approval. Now, very well, could we have some more data later? Sure. But like with the antimicrobials, they were only studied in women. So we have no data in men because and for example, nitrofurantoin and fosfomycin do not work in the kidney. They don't penetrate the kidney. So we're never going to have complicated UTIs that are pyelonephritis with those two antimicrobials, men or women, it doesn't matter because they don't penetrate the kidney. So, they went for the first main treatment that they're going to get, which is uncomplicated UTIs in females.
I think the only other thing to add to that is the precision trial authors for suzetrigine or Trivio. They did pull out the study population of African-American Black patients due to the higher rates of resistant hypertension. There was a slightly blunted response, but very similar as the overall population.
Thanks so much. Great questions, and we'll see you next time.
You got your flash drive, right?